Hello, and a warm welcome here on a sunny Friday morning here in London from the ISNTD. My name is Kamran Rafiq. I am the co-founder and communications director here at the ISNTD. Welcome to our weekly ISNTD Connect broadcast. We're not doing it at the normal time, a slight departure from the 2 o'clock afternoon slot. We've got a bright and early 9 o'clock start today. Today we're kind of celebrating the fact that it's World Nutrition Day. That and the launch of a very special brief put together by the partners in terms of this panel, the panelists that we have here, the various organizations, Unicef, the Asia Pacific Leaders Malaria Alliance, and also the Asia Pacific Malaria Elimination Network, APLMA-APMEN, and also the RBM Partnership to End Malaria. I'm very honored to be joined today by representatives of those three organizations. So starting from the top, Ms. Amita Chebbi, Senior Director of the Asia Pacific Malaria Alliance, Asia Pacific Malaria Elimination Network, APLMA-APMEN. Good morning to you, Amita. There. Hi there. Dr. Lola Dare, we have the board member of the RBM Partnership to End Malaria and president of CHESTRAD Global Development Synergies. Hi there, Lola.
Thank you.
And also joining us from Bangkok is Dr. Roland Kupka from Unicef in terms of the Regional Nutrition Advisor for East Asia and Pacific. So good morning to you, Roland, as well. Hi there. One of the reasons we've kind of convened this, there are a lot of crossovers and a lot of kind of, how to put it, overlays in terms of nutrition, malnutrition, nutritional deficiencies, and malaria. Obviously, infections and nutrition are closely related in terms of their effects on metabolism and immunity. When you overlay this with socioeconomic conditions, limited health system capacities, all of these add to the risk of both infection rates and poor nutritional outcomes. Malaria and malnutrition coexist in a very vicious cycle, as malnutrition and key deficiencies, brain deficiencies, an example, can increase the risks of developing severe malaria and lead to increased morbidity and mortality from infectious diseases in general. Malaria is a very good example of that. Infection with malaria can push children and pregnant women into a malnourished state. And in 2018, some of the figures around this, a staggering 11 million pregnant women in sub-Saharan Africa were infected with malaria, and consequently nearly 900,000 children were born with low birth weight, i.e. less than 2,500 grams, which puts babies at a far higher risk of death, stunting, poor cognitive development, and poor life outcomes because of that. LMIC settings, low and middle income countries where resources to support health systems are often limited by definition, they bear the majority of the burden for the disease burden for malaria, but also for malnutrition and anemia. So there's a huge case being built for the integration of nutritional activities with malaria services, and it's really being put forward as a consideration for better effective case management, especially when you look at the most vulnerable groups. And within that, malaria workers can play a vital role in the delivery of malaria and nutritional services, which I guess is part of the reason that these three organizations have come together with their brief that's been put out, launched today. And obviously, we're very, very happy to kind of welcome everyone to this particular panel. I thought we'd get things started off. What I would say to the audience in the chat, and thank you for joining us. I know that we've got a lot of people joining us. So the youth parliaments of 16 African countries represented by the SADC Youth Task Force on Malaria and NTDs. The head, Maximilian Godwin, has joined us from Tanzania. We have from Paris, Dr. Halusafakova, from Iran, Dr. Majid Harandi. We've got a lot of different people coming in from different areas, from Spain, Edith Gonzalez. And I would ask you all to please do say hello and put your organization and your country into the chat, and please feel free to start putting any questions to our panelists as we start. So I think that's kind of enough of a kind of an overlay in terms of where we're kind of going with this particular panel. So I think it might be a good idea to kind of get things started in terms of just hearing from the panelists, their opinions in terms of and their kind of viewpoints in terms of malaria and nutrition. So I'll start this off with a general question, and we'll go. We'll start with Amita first. But the general question to all the panel really is: how exactly are malaria and nutritional challenges interrelated? So I think I'll ask Amita that first.
Thank you. Good morning, Kamran. It's really lovely to be here and to talk about this incredibly important, pressing issue that has implications, I think, for the health and well-being of children all over the world. I represent the Asia Pacific Leaders Malaria Alliance, as you said, and we're, for the benefit of all our listeners, we are a regional coalition that consists of heads of states from 22 countries in Asia Pacific, all of whom have committed to the goal of a region free from malaria by 2030. I am a senior director at the Secretariat here. Now, over the last few years, the region's made incredible progress towards this goal of elimination. So just over the last 10 years, for instance, we've reduced the number of malaria cases by half. The number of deaths due to malaria have reduced by 89%. And today, the region as a whole, the Asia Pacific region as a whole, really accounts for only between 4 to 5% of the total global burden of malaria. So as you can imagine, some really good, robust progress here. But increasingly, as we work towards that elimination goal of 2030, we're finding that the last remaining cases of malaria are really concentrated among marginalized and vulnerable populations. And so malaria, if you just look at the burden, the map and how it's changed over the last few years, it's really receded away from capital cities, from urban centers, from even semi-urban centers, and is largely concentrated along the borders of all of our countries, concentrated in tribal areas, and really among hard-to-reach geographies. So it's really becoming a disease of poverty today as we speak. And when you think about it, and you think about undernutrition, the causes for undernutrition are also rooted in poverty, right? Whether it's around, causes related to food insecurity, a lack of access to health services, or even inadequate care and feeding practices. So, both malaria and malnutrition really bear the burden of poverty, as it were. So there's a high degree of overlap as far as populations are concerned that are affected by both malaria and undernutrition. And you will not be able to make progress on one without addressing the other. You talked about the vicious cycle and the interconnectedness. So when we look at the progress on malaria elimination that we've made in the region over the last few years, some important themes emerge which I think will be relevant for this conversation. In our experience, some of the key drivers that have really allowed us to make this progress on elimination have been, one, the robust investments in the malaria programs. Some very strong financial support that's been available to these malaria control programs in the region. The second is investments in health systems more broadly. So, it's definitely building those capacities, whether it's the capacities of frontline workers, capacities to be able to analyze data, capacities in surveillance systems to use data for decision making and make changes to the program. And the third important driver really of this progress has been a keen focus on improving access among marginalized communities. So we've come a long way, but I think still lots of miles to go. So we would like to use this opportunity to leverage some of the lessons from our experience and elimination in malaria in the region and see how can we bring those to bear in a more integrated manner, really looking at undernutrition as well, and leverage some of those experiences. So as part of this today, for instance, we've just entered into a partnership with WHO's Partnership for Maternal, Newborn and Child Health, and hope to be able to leverage our experiences and lessons learned both for malaria as well as nutrition. Thank you.
That's a great answer, Amita. Thank you very much. And some very positive impacts that you mentioned there in terms of the work that you've already started and some of the leverage that you've mentioned just there to end that with. So very positive answer in terms of that. And again, underlying this kind of drive for integration between the two worlds, as it were. I'd like to ask that same question to Dr. Dare, to Lola, if that's okay, in terms of how are malaria and nutritional challenges interrelated from your perspective, Dr. Dare?
Thank you very much. Like Asia, we have made significant progress in Africa in reducing mortality and burden and the disease burden due to malaria, but there's still so much to be done, especially amongst women and children. Yesterday, we celebrated World Children's Day. And our theme in Children's Day was to stop the disruption of education due to malaria, the disruption of employment due to malaria, and the economic impact of malaria that still continues to decimate many of our communities where they live, work, and play. And so it's very important for us to begin to identify malaria not just as a disease, but as a disruptor of education and human capital development. And so in our work, we look at how malaria keeps children away from school, and it's linked to nutrition is really very key. It's like it's already said, there's a link between nutrition, poverty, and malaria. But there's also an evolving difficulty in even rich Lagos State, where we have urban slums. The rise of populations and the migrations of populations into urban slums in Lagos pose a different risk for malaria. And so we're also looking at how we're going to reach children and women in urban slums with very much needed treatment for malaria and nutrition in an integrated package that contributes to human capital development. The last bit of it that we are beginning to learn from COVID is that indeed primary healthcare systems matter. They matter to nutrition, they matter to malaria, but they are also significant to social protection. And financial services for women would enable them access the services they need, purchase the food they need, and also ensure that their children have access to malaria treatment and prophylaxis when it's necessary. So it's such an interwoven, the concept of malaria, nutrition, poverty, and human capital development is so interwoven and is right on the table, and COVID calls our attention to it more than ever before.
That's a great answer as well, Dr. Dare, really reimagining malaria from just a specific disease kind of optic into a far wider context in terms of this human development. You mentioned schools and all different types of measures around the impact for malaria, and certainly how you described COVID, it's really shone a light on the inequalities at societal level, at healthcare system level, right across the world. And so I wonder what the Unicef, the view on that is, Dr. Kupka, from Roland, in terms of the malaria and nutritional challenges. What are the interrelated points from the UNICEF point of view?
First, I really support what the other colleagues have said. The focus on the most vulnerable, being aware of the underlying social drivers is very important. Perhaps to add to the discussion, I mean, there's also this well-described physiologic interrelatedness between infections and malnutrition. We know that forms of undernutrition, such as wasting, deficiency in key nutrients, such as vitamin A or zinc, increase malaria morbidity and mortality. And we also know that malaria, in fact, worsens nutritional status, changes the metabolism of these nutrients. So there's also very strong physiologic basis, a physiologic interrelatedness. And then also, and building on what the others have said, a very strong programmatic rationale, because we need to manage malnutrition, we need to manage malaria in the same health system, through the same health cadre, through the same community systems, and it only makes sense to link interventions in those systems so that we achieve optimal outcomes for those who are most at risk, as we heard, young children, those during pregnancy, and especially in settings such as Sub-Saharan Africa, where there's a large remaining burden, of course, as well as the pockets that we've heard about in parts of Asia.
Fantastic. That's a great answer. Thank you, Roland. And don't worry about the sound. These things wouldn't be a live webinar if something didn't go wrong with the sound. So we got that out of the way at the beginning. So fingers crossed for the rest of it. But that's a great answer. Thank you for that. And so, I mean, as we've heard from Amita, we've heard from Lola, we've heard from Roland in terms of how, from Amita's case, some of the more marginal cases and the more marginal vulnerable communities are kind of bearing the brunt of the disease burden for malaria at the moment, making that unit cost in terms of reaching the last remaining parts of the malaria disease burden a lot harder when it comes to reaching those particular communities. From Lola, we've heard in terms of some of the challenges around sub-Saharan Africa and that perspective, and kind of reframing malaria, and from Roland a little bit about the UNICEF's kind of perspective on both, and again kind of reiterating the need to further properly integrate the two kind of systems or approaches, as it were. So just addressing that disease burden in sub-Saharan Africa for a minute, I'd like to ask Dr. Dr. Lola, what are the particular challenges from your perspective facing sub-Saharan Africa, the region, when both malaria and nutrition remain two of the leading causes of death in children under 5? You're talking about children under 5 being particularly vulnerable to both malaria and malnutrition. What are your kind of views on the specific challenges? You mentioned some of those, Lola, in terms of some of the points you mentioned before, but kind of drilling down into that, what would be the specific kind of challenges from a sub-Saharan African perspective?
It is very clear to us that as overall mortality and morbidity to malaria drops, our overall death rate as a population is also dropping. And so we're very clear that investing in malaria is investing in health. However, the challenges remain the availability of quality services to people where they live, work, and play, and the systems of supervision and referral that ensure that it is delivered to them when they need it, in the quality they need it, and in the quantity they need it, all over. Malaria is not a respecter of it's not a respecter of wealth. It's not a respecter of class, and it's not a respecter of gender. And so that cross-cutting nature means that it's not only a health sector issue. So for us, it's also very clear that malaria is not something you wait for in a clinic. You go and meet the parasite where it is. And so you don't wait for the malaria in the clinic. So there are many dimensions to integrating the treatment of malaria. There is the health sector dimension, which is making sure that a woman at home has access to preventive therapy, antenatal care, so that the high-risk malaria, high-risk events in pregnancy is detected, and the impact of chronic and endemic malaria on low nutrition is early detected in pregnancy before it's time for childbirth. But going well beyond that is also malaria as a disruptor. And so for children under 5, we see malaria as a disruptor. So we begin to look at the interconnectedness of the sectors and how we need to impact on early learning, especially early learning. Children just don't go to school because they have malaria. Mommy doesn't go to school because they have malaria. Daddy doesn't go to work because he has malaria. And so there's really a conundrum of how malaria then begins to affect employment, it affects education, and then vector control means that we need to work with the environmentalists to ensure that we have the right environment to reduce the breeding of mosquitoes. This complexity is still what we have not gotten our hands on. We have moved well ahead in the issues of treating malaria, prophylactic treatment for malaria, but integrating a malaria delivery package and also financing a malaria delivery package that ensures that we can impact on human capital development in a strategic way from 0 to 5 years is something we still need to pay greater attention to. The data is also an issue, and we're very excited that the Bowback Malaria Board, the End Malaria Board, is also working on the malaria dashboard that's engaging many of our countries and providing information across countries that allowed us to even exchange materials during COVID, exchange bed nets, exchange that. So data is very important, and the dashboard is very important in helping us to share that information and respond. Perhaps more importantly is innovative financing for malaria. Linking malaria to COVID, linking malaria to nutrition, presenting the investment case that shows that malaria is not just a communicable disease. It's a disease of it's a disease it's an anti-development disease, and financing the response in such a way that the financing is robust from public budgets and more is something that we need to do. We learned from COVID. We can fund from private sector, we can fund from philanthropy, we can also fund from public budgets. Let's do it.
Well, that's a fantastic answer. I love the fact that you've raised a challenge that there's so many different sectors involved, and I wonder what type of lingua franca, common language, needs to be adopted between those sectors. Perhaps you've alluded to it in your dashboard. Maybe the dashboard is the actual answer, giving somebody, giving all those different silos, as it were, different disciplines, something to kind of communicate around in a common way. So perhaps that dashboard has a lot more mileage to it than we it's kind of I think that will develop as something that everyone can use. That's a very positive answer. We really appreciate that. You mentioned COVID, Lola, as well, and I think I'll turn my next question to Roland and ask, really, from UNICEF's perspective, how has the COVID-19 pandemic affected both the nutritional activities and malaria, from your view?
Mm-hmm. Yeah, thank you, Carmen. That's a really important question, and I think, put quite simply, the pandemic is threatening to disrupt years of progress made in both malaria control and in nutrition, and it's threatening to widen disparities in health and nutrition outcomes. There are some countries who've done a marvelous job at protecting malaria control and prevention programs in the context of COVID, including here in Asia. But we know from global analyses that, the pandemic has disrupted important services, case management for malaria by, according to some estimates, more than 30%. And that's really, really troubling, because we know that in settings such as sub-Saharan Africa, 25% drop in drug coverage would lead to an additional 100,000 deaths in that geographic region alone. And really importantly, that it's yet again the vulnerable populations in fragile settings that will be hardest hit. The child living in a conflict setting, the child living in a part of the country where the health system is not working well, where it's been derailed, or the child whose family just lost its income and they're not able to overcome now barriers to health services. So in nutrition, what we're seeing is that COVID has disrupted food supply chains, it's lowered incomes and purchasing power, it's disrupted the availability of healthy foods, and that therefore millions of people are forced to consume nutrient-poor, unhealthy alternatives. And the health systems are not able to provide the nutrition services these populations need. Education systems have been disrupted. Children are not receiving the services, the school meals that are often the only meal they've been receiving. So really what we're seeing in nutrition, that even though children are not primarily bearing the direct effects of the pandemic, they're not the primarily affected part of the population in terms of infection, but the socioeconomic impacts, the effects of the control measures are very much affecting children, so that there are estimates that show that more than 9 million children will be wasted next year as a result of COVID, 2.6 million children stunted, close to 170,000 children who will die, and more than 2 million additional cases of anemia among mothers. So certainly without concerted actions now, many children will lose their lives, and also the effects of the crisis will be felt for years. We'll be putting a large question mark on the future of this generation, of subsequent generations, if the right measures are not taken now.
That's a great answer. And I was kind of staggered, actually, Roland, in some of the kind of background to this, the landscaping around this. You mentioned anemia. Clearly evidence shows that the low birth weight can have really adverse impact throughout the lifetime for that particular individual. And you mentioned that is on the increase if unchecked through this COVID situation. So all those outcomes, could be affected in a negative sense by that. Malaria accounts for an estimated 3 to 15% of anemia and 25% of severe anemia in pregnant women in malaria endemic countries. Staggering. statistics on their own, let alone when you add in this COVIDization of everything. It's very interesting, some of the points you mentioned there, Roland. When it comes to vector control, we've always found, some of our panels we've had in the past to look at the effect of COVID on vector control activities, is that the vector control activities that were enabled or had some point a tech base to them, so an app or something like that, they were really seen to be kind of COVID proofed. And I wonder if within the malaria setting, we can probably ask that out at a later point in this session, if the at least the vector control activities that are underpinned by using tech such as an app, maybe they would be more COVID proof in terms of impact by COVID, but that's something we can open later in the discussion potentially. I'd like to thank you for those answers, both of you. I'd like to answer a question over to Amita in terms of, we've heard in terms of the challenges facing sub-Saharan Africa, we've heard of the kind of new world that's appearing in front of us because of the impact of COVID. And I wanted to ask you, Amita, what are some of the opportunities and challenges with integrated approaches for case management in particular?
Yeah, I mean, COVID has really been devastating, in terms of its impact on lives and livelihoods. And certainly, I think a very sobering message here from Roland in terms of, what that could potentially mean for nutrition indicators, nutrition outcomes for a lot of our children and, women. But at the same time, I think COVID has really been a kind of a catalyst to accelerate some of these conversations around integrated approaches to case management. And this is happening in the backdrop of some key shifts that are taking place that I do want to touch upon before I come to the opportunities. I think the first one is sort of, the economic impact on health budgets that COVID has had. We're seeing that there's a global economic contraction spurred by the virus. The World Bank estimates that the growth in public spending on health is definitely going to decline, and so this does raise some very difficult questions around how ministries of health are going to make those choices around where do they allocate their constrained resources. The second piece, which is probably more relevant for some of our countries in Asia Pacific, is the transition from donor-funded programs. Over the last few years, there's been a lot of investment in the region, particularly in the Greater Mekong sub-region, in terms of support to malaria control programs to really address the challenge of drug resistance. And these investments have borne fruit. We're seeing that, I talked about some of the progress that the region has made, and this has been a direct result of those significant investments from partners like the Global Fund as well as other donors. But as the burden is increasing, and as these countries are, have demonstrated good economic growth, they are no longer eligible for, for some of that support, right? Whether it's from a global fund or others. And so a lot of the countries in our region have had to start thinking about transition, about sustainability. The reason I mention this is because this is really giving rise to some very unique opportunities, I think, at this point in time. The first one is it's providing an impetus for us to think about cost-effective models of service delivery, in the context of, reducing fiscal space for health, where ministries of health have to think about, where to allocate resources. They really need to demonstrate how resources can be optimized, how to reduce wastage, how to enhance efficiency. And I think an integrated approach to case management that is cross-cutting between malaria and malnutrition could be one way to address this issue of constrained resources. The second piece is around the transition and sustainability. Like I said, a lot of the programs in the region resulted in significant investments in health infrastructure, whether it's frontline workers that have been trained and deployed to go out into communities and diagnose and test and treat for malaria, or the investments in surveillance systems. And so as the malaria burden is coming down, we have access to this infrastructure and need to think creatively about how to utilize some of that infrastructure for non-malaria health areas. Are there linkages that we can build, bridges that we can build between malaria and nutrition? And some early work has already gone on in this space. So in Myanmar, for instance, and I want to share this example, there's a program that was supported by Malaria Consortium, where they trained and deployed malaria volunteers to focus on integrated community case management. So these were malaria volunteers who had already been trained on malaria diagnosis and treatment by the National Malaria Program. They were then provided additional training to focus on diagnosis and treatment of pneumonia, diarrhea, and to detect malnutrition in children under 5. And so this expanded role really addressed two objectives. From the Ministry of Health's perspective, they were able to strategically address a broader health concern beyond malaria, really targeting, vulnerable constituency of children under 5. And at the same time, from a malaria volunteer perspective, it provided greater motivation to those volunteers to continue providing services in the community in a context where there's a declining caseload. So they were just not seeing as many malaria cases, but we're not at elimination. And so you need to still be there to provide those services, but how do you better leverage your time and energies? And this was one, great program that looked at cross-cutting approaches. I think the third opportunity, which I do want to talk about, is the fact that an integrated approach to case management will really help us center communities at, in the middle of it. We talked about community engagement for the longest time, and I think there have been some really interesting, innovative approaches. But an integrated approach that brings together malnutrition, malaria, will really help us place the communities that we seek to serve at the center of it, build an intervention and approach that makes sense to them, and really pivot them from just being passive recipients of the interventions to more active owners and engagers of the services that they offer. So I think this was on the opportunities. Do you want me to talk about the challenges, or I can take a pause here?
Well, we can. That's a great answer in terms of the community-centric approach, and certainly that's going to be the vital part of the puzzle as we go to the elimination targets, as you've outlined before. I think it's a great answer. I would like to come to. I was going to expand on that community thing. I'm going to ask Lola actually this question, and perhaps then come back to Roland to get his view on it as well. Amita obviously just mentioned there the role of the community becoming more prominent. I suppose moving from rhetoric into actual action in terms of their role within this whole community engagement, getting them on board as we reach the eradication targets. From your opportunity, Lola, from your perspective, Lola, what is the role that the community can play in promoting an integrated approach to tackling malaria and malnutrition?
I don't know if you can hear me.
Yeah, we can. Yeah.
Oh, fantastic. I think the statistics from UNICEF are actually quite stark, they're actually quite stark and disturbing. And one of the things we need to do is to communicate those statistics, not just to government, but to people. Because our people have lived with malaria and it's endemic, sometimes they don't take the critical prompt action that they need to take. And we have in some way been negligent in communicating the risk, the opportunities, and the self-protective action that people can take away from communities. It's been quite a while where we went out to communities and cleaned out their drains and helped them to see what simple environmental-based procedures that they can take to reduce malaria. As we continue to reduce we continue to distribute insecticide bed nets, and we want them to use it. And so we need to also work with government and communities to tell them the impact and the benefits of sleeping under a bed net. And I think we need to put more energy into that. But for us here, I think the biggest thing that communities can begin to think about is that word transition. Governments, communities, and private sector in developing countries need to begin to think about how to sustain the achievements that we have made so far with the help of UNICEF, the Gates Foundation, the Global Fund, and many other funding partners. It's not going to continue forever. So financing at community level is a very important way forward. It's a very important discussion with communities going forward and also with governments. What else can communities do? There are key messages we think that communities need to amplify, and the broad range of civil society organization needs to amplify to governments, amplify to communities, and also amplify to stakeholders who can help them to take action. Let me just mention just a couple of them. Children under 5 are our tomorrow, and mothers are the receptacles that nurture them. They are exceptionally susceptible to malaria with malnutrition and anemia. We need to protect them now. The limited access to financial services and social assets expose women and children to greater risk of malnutrition and malaria. We need to ensure that women have access to financial services that will enable them purchase services, especially for malaria, which they hit every day, when they need it, where they need it, and close to home. Malnutrition, malaria, anemia, and poverty, it's a vicious cycle, and we need to continue to link it to human capital development. It's a very important message at community level that your child will not survive, your child will not excel, and your child will not thrive if you do not prevent malaria at home. So in our communities, we tell them, survive, thrive, and excel, kick out malaria.
That's a great answer, very positive answer, and I think centered on sovereignty and a sense of ownership of this problem at community level. So I'm sure there's lots of work ahead in terms of filling some of the gaps that are probably going to materialize around educating the community to the outcomes that they're facing without tackling this in an integrated manner. So thank you for that, Lola. Just to roll back a little bit in terms of, from an operational perspective, Roland, what are UNICEF doing in terms of combating both malaria and malnutrition at the moment?
Thank you. First, given the previous discussion, let me perhaps start with just a few thoughts on COVID and the COVID response. And I've mentioned a lot of the service disruptions that we've seen, but what's also been really amazing is the innovations that have occurred in terms of the use of digital technologies for program monitoring, for surveys, for training staff, the opportunities to simplify protocols, for instance, for the treatment of malnourished children would have never occurred, I think, in the absence of COVID. And then perhaps most starkingly, the expansion of social protection programs, especially in this region. This happened at a pace that was never thought to be possible. So I do feel that there's a lot that we're learning, in the context of COVID, and that we as an organization, as UNICEF, really are trying to take forward as well. And I think one of the biggest privileges really with working for UNICEF is that we work across so many different areas, health, nutrition, education, water sanitation, social protection. And that really puts us in a position to work across those areas and to strengthen relevant systems, both in development context as well as in emergency context. We're also able to draw on a strong supply division, as many of you know, that enabled us in the year before COVID struck to support 33 countries with the procurement of essential medications, including for malaria, for bed nets, other key commodities. But I think really importantly for our programmatic work, what's becoming quite clear, especially when we think about nutrition, malaria, is how to strengthen systems and how to reach vulnerable populations. So this, makes us grapple with antenatal care. How do we reach pregnant women with intermittent preventive treatment during pregnancy, or children with seasonal malaria chemoprophylaxis where that's needed? And then really importantly also how to strengthen community systems, the integrated community case management. So for instance, in 28 countries in sub-Saharan Africa, we were able to support governments on implementing this approach. And we also, getting much better about integrating nutrition into these systems. Broadly speaking, we were able to work with 80 governments in 2019 to help them reach children with services to prevent malnutrition. We were able to reach more than 60 million adolescents with service to prevent anemia, help with the treatment of 5 million children for severe wasting. But we also realize that there are huge untapped opportunities still that also the others have talked about to bring services together, to seek synergies in delivery platforms. So also in the context of COVID, we're trying to bring these services together, for instance, at the level of schools, to link water, sanitation, health, nutrition interventions at the level of schools, and also to, again, strengthen the treatment of severe wasting in health systems. As one sign of that, 8 countries in the Asia-Pacific region, coupled with 15 countries from other parts of the region, have committed to strengthening the prevention and treatment of wasting, and specifically the better integration of these services into routine primary and community health services. So I do feel there's there's a lot of work that needs to be done, but also a lot of really exciting work that's happening, and that's trying to bring these services together to help children be more well-nourished, and to be resilient to malaria and other key childhood killers.
That's another fantastic answer from our panelists there. You mentioned supply chain, Roland. We had a very interesting supply chain panel with Unicef, actually, and a few other partners a few weeks ago. One of the outputs of that was that there's a very interesting line that came out of that, which was that sustainability. Well, supply chains will be the touchstone for sustainable practices in the future. There are so many aspects, as you just mentioned, in that would play to this type of integration across different sectors, that I think that's something that's definitely going to be explored moving forward in this mix. So it'd be very interesting to keep an eye out for that. But thank you for your answer. Amita, you mentioned earlier the kind of opportunities. You touched into some of the challenges, and we kind of left it there to come back to you. So I'm going to come back to you now and ask you in terms of the challenges in terms of case management.
Yeah, so I mean, I think, like you said, lots of opportunities for integration, but also have to be cognizant of some of the challenges and to think a bit more deeply about what we can do to mitigate, the risks associated with these challenges. I think, to sort of kick off, the first thing is that there really isn't one single model of integration. You need to develop integration models that are suitable for the country's context, for the sort of, the situation that they are in. And to be able to do that, you need access to data. So I think the first challenge is actually around the absence of, granular data at the subnational level to really be able to develop these kind of models for integration. And I want to give you an example, again, from our region here, which talks to this data issue. So in the Greater Mekong sub-region, the malaria burden has historically been concentrated in young men who go to the forest for their livelihood. So they're known as forest goers. And a lot of the programming over the last 10 years has been around interventions that are targeted at these forest goers. And, there has been progress made, burden is coming down. But we talked about some of the stubborn pockets where, transmission continues to exist and where the burden remains. So in the context of, one of our partner countries, this is the Lao PDR, they found that actually, malaria burden was persistent in 3 districts, right? Started diving a bit deeper into the data, and they realized that actually that remaining burden there was not so much in the forest goers, but it was in these communities that practice cultivation on the edges of the forest. And so those communities, really it was sort of family-led cultivation. So, men, women, children. And the burden there was not concentrated in the men, but equally spread out between men, women, and children. And so, now the government is really thinking about a more innovative accelerator strategy to address, very unique changing demography of, the malaria burden there. But that would be a community that would be ideal actually for an integrated approach, looking at cross-section of nutrition and malaria, because it addresses, the women as well as the children in those communities. But to be able to do that, you need data. So I think the first challenge is access to data. The second challenge is really around, need for more evidence really around what are the operational models that would work. So I would say, if you look at the evidence base, we're still pretty thin on the ground in terms of actual successful models of integration that work. We talked about the Myanmar example and the Malaria Consortium program. That's a great example, but it's really one and might not, and the evidence from that might not translate quite easily to all countries. So need to invest in developing operational research, implementation research models that can help you unpack some of the ways in which this integration can work. Is it, integration around, for instance, integrated referrals? research around how best to train some of those frontline workers on cross disease areas. Supply chain and logistics, I think, is an important one that's ripe for operational research, really. When you think about adding more on, what does that supply chain look like? And I think the last one is really the big one in terms of a challenge. It's the need for continued financial support, to operationalize some of these integration models. So, of course, there are going to be benefits from optimizing resources. Cost effectiveness will come through, but a lot of that will come down the line. And upfront, there will be some initial additional investments that governments need to make to be able to build those operational models out. Firstly, around, for instance, integrated surveillance systems. Right now, I think one of the biggest banes of the global health community is that each disease area has its own surveillance system. When you talk about integrated case management, how do you have an integrated surveillance mechanism? Looking at training models, for instance, frontline workers will need strong, robust, adequate, appropriate training to be able to take on these additional, services. And what should that training model look like? Reporting mechanisms, need for additional incentive models. So there's a lot, from a health system perspective, but it needs financial investment, and I think that's going to be a big challenge. So yeah, thank you.
That's a great answer. When you were talking about the various points within that, my mind is lighting up in terms of the role of the community again within that, potentially to help, even up to the financing point. And by that I mean, if we're talking that one of the backdrops is a decrease in terms of charitable funding going into this area, which is a given in terms of where we are now as a global community with COVID to fight and all sorts of political challenges ahead, that's going to be decreasing, fine. It kind of underlines the fact that this is going to become more of a sovereign wealth issue in terms of the sovereign governments themselves putting money into these type of, especially into these integrated programs, which can show a result across various efficiencies, across various scale-up processes. They work, as you mentioned, evidence has to be gathered, but I'm sure that will start happening. And so I suppose the role of the community in terms of helping the political class understand that they need this and that they should be releasing capital into these kind of programs is going to become more vital. So I suppose the role of community advocacy in this is going to become more and more applicable. So that's a great answer in terms of the kind of challenges around those particular approaches. What I would ask is, what would be, you mentioned some of the success stories and things there, but in terms of the, how to put this, would there be kind of key messages for those policymakers thinking about perhaps looking at or considering a more integrated approach? Would there be any kind of key triggers to pull for the policymakers? I'll ask. I'm going to ask that back to Amita. I know you just answered. I'll ask that to you, then I'm going to ask Lola and Roland as well. What would you say, in a nutshell, to the policymaker to take on this case of integrated services?
So I actually want to share an anecdote, and this is from a few years ago when I was working on nutrition in India, actually. And, in India, nutrition is sort of the responsibility of the Ministry of Women and Child Development. Health is the Ministry of, Health. And there's been a lot of talk about how do you integrate nutrition into health services. So we had a big meeting, one of those multi-stakeholder meetings, lots of discussion, conversation on integration. And at the end of the day, one of the ASHA workers stood up. So the ASHA worker in India is a community health volunteer. She's a frontline worker who's responsible. And, she stood up and she said, well, we've been talking about integration, but quite frankly speaking, at the community level, I'm already integrated. I am responsible for delivery of services, whether it's health, whether it's nutrition, whether it's, some of the education services. So as far as we are concerned, we are integrated. The integration really needs to happen back at your ministry level, across your different divisions and departments. And I was reflecting on that today and thinking that's such a powerful message. And I think from a policymaker perspective, really thinking about what can we do to empower that frontline worker and make it easier for her to deliver these integrated services. And going back to, the challenges, I think my message would be, how can you invest in those kind of integrated surveillance systems, really invest in training, have a mechanism of supportive supervision for this frontline worker, so that she stays motivated, she stays engaged, and there's a feedback loop that's coming back. How do you invest in, aligned reporting systems so that the frontline worker is not just spending all her time filling out multiple forms and reports, even if they're, on a digital base. So yeah, I think investing in health systems that are integrated would probably be my one message to policymakers. Thank you.
That's a fantastic answer, Amita. And I wonder how the backdrop of UHC, universal healthcare, will play into this kind of momentum in terms of giving more, I'll use the word power, but more resources, more power to the community health worker, the primary health care worker. I wonder how that's going to impact in terms of further integration of these particular areas and services. That's a great answer. Thank you very much for that. Lola, in terms of your the sub-Saharan African perspective on that, what would you be saying to policymakers right now to make this happen?
You said something very important. Global philanthropy is dropping, but hey, domestic philanthropy is rising.
Yeah.
And this is an opportunity for blended financing. A couple of months ago, the BUA group in Nigeria committed $100 million a year to health and development. What are we waiting for? Tony Elumelu, Dangote Foundation, Mo Ibrahim Foundation. Every other month, a rich, wealthy billionaire in Africa sets up a foundation to give back to Africa. We're at a moment where we can blend financing, but policy is still very far away from blending financing. The paradigm shifts that the policy, and I like what Asamia said, it's not happening. We are blended at the community level. We need to think of blending at the policy level and blending at the at delivery level, at ministries of health. That's where the biggest blending needs to occur. So the key message to policy is take advantage of the opportunity COVID has offered to us and blend. The second message is integrate. So we call it reimagine, innovate, integrate, and blend. How do you integrate? We also have the opportunity to show that research has linked malaria, nutrition, financial services to human capital development for economic impact and social transformation. This is what we need to be talking about now. How do we ensure that we're presenting to policy the investment case that enables them to put domestic resources and not think they're putting it into a disease, but they are putting it into human capital development. And that's something that we would benefit from a joint action with the global community to do, to ensure that the language from above and the language from the vertical and horizontal language is aligning. The last thing is for communities. Community giving is real in Africa. In fact, if we have too many infrastructure, it's because community builds their own health center. Everybody builds their own health center. And so there is a lot to reshape and reimagine the value-based impact of community giving that we also need to communicate to our communities and to our partners, including Unicef. So I'm glad Unicef is here. I'm glad everybody's here. We can actually reimagine community giving and make it more impactful for malaria and nutrition than we've ever done before. Thank you.
That's a fantastic answer, building that socioeconomic case. Perhaps that's some of the additional research that needs to be put out in peer review form, not just the mechanisms of nutrition and the effect to infection, but actually the case in terms of the effects to GDP. And that certainly is a language the policymaker would understand. So I totally understand why you said that. It's a great answer, Lola. Thank you for that. Coming to Roland, UNICEF often seen as the kind of the honest broker between the policy world and you're in that position whether you like it or not, because you're operationally active, you're working in these communities right across different silos. What would be UNICEF's kind of message to the policymaker?
I mean, I think on the one hand, and this is building on Amita's points, I think what COVID is showing us is the importance of risk communication, community engagement, institutionalizing community health. I think we knew this sort of before, but I feel COVID has really elevated the importance of that even more, the importance of primary healthcare, reaching vulnerable populations. And also, I think, and this is the subject of our discussion, integrating supply systems, monitoring systems, and recognizing also that sometimes, the odds are a little bit against us, given that some of the funding that we receive is very vertical and sort of requires us to report in an isolated fashion. But I do think we were getting more and more clear what is important. Perhaps related to Lola's point, and I think one, and this is certainly the case from the nutrition perspective, one area that we're not mastering very well is the whole area of public financing. And again, this is so relevant in the context of COVID, and for us first to be able to document, how our children, say in Unicef's case, being affected by COVID, by the socioeconomic impacts, to then be able to determine what kind of social protection programs are needed that are then also sensitive to various needs of children. And then thirdly, and this is perhaps my main point, is then to also see then in upcoming government budget discussions and in the context of possible reduced revenues, how to defend the best interests, the priorities that children deserve in those discussions. I feel certainly from the nutrition side, we have to get much better at that, to understand how these budgets are put together and how to influence those.
That's a great answer again, Roland. I love the fact that you keep mentioning this at the supply chain and the opportunities within that, because I think that's a very interesting angle to pursue, with a lot of wins in terms of all of the touch points along that supply chain issues, as it were. I'm coming to the close of the session. I'd like to just kind of quickly get a couple of questions in from the audience, if that's okay with the panelists. We have Professor Majid Fashihi Harandi from Iran, and asking, is there any evidence of gender inequality for nutrition amongst children leading to more death from malaria in girls rather than boys? I'd ask, we can ask Lola that first, if you're on my right on the top. You're on mute, sorry, yeah.
Certainly, there is a lot of gender inequality and social injustice in the access to nutritional services and in access to quality health services. When in urban slums that we work in Lagos in a project called Tariro, we have identified that 67% of the women do not have access to services, and more than 70% of them are not financially included. If you are not financially included, you cannot purchase services and you cannot purchase food. We also find out that more than 80 to 85% of the middlemen, that's why they call them middlemen. They are principally men, which also means that purchase of food and payment for food is driven by a value-based system that is very gender inequitable. Finally, our response to COVID has also been gender blind. And so COVID has shown us that the gender inequity is not just in access or in financing, it's in the whole way the system is structured. And so we're calling for gender-sighted COVID-19 response that links to primary healthcare and social protection. So there is a lot of evidence that there is a gender disparity, and indeed also a youth disparity in the investment in COVID and investment in healthcare systems.
That's a great answer, thank you. Well, Roland, would you like to add anything to that?
Yeah, I mean, I obviously fully support of what Lola has said. Perhaps two additional points. I mean, one is that we have big data gaps. It gets back to the data issue. When we look at our programs and when we see also with services that are being made available to boys and girls, what are some potential gender dimensions? We know from some evidence from South Asia that, feeding practices are worse to girls as compared to boys. But what is quite interesting in the area of nutrition is that when you actually look at surveys from different countries, it's actually boys that have slightly higher rates of malnutrition than girls. And there may be some biological reasons for that, because generally, the infant girl is more sturdy than the boy. But there's certainly a lot that we need to learn, and as Lola said, be really clear that gender inequality is one of the main drivers of malnutrition, without any doubt.
Fantastic, that's a great answer, thank you. Amita, would you like to add anything to that, or there's one more question I can ask, or in terms of gender inequality? What's your view on that?
I think just one more angle, and this is really around innovation, and particularly when you think of research and development. And from malaria, when you are talking about Plasmodium vivax, which is a particular form of malaria, there still needs to be a lot of investment in R&D, for new tools and technologies and treatments. And really looking at it again from a gender perspective, are the tools and technologies appropriate for women? Can they be used in pregnant women? I think that's an angle that we've been focusing on and trying to make it more equitable.
Fantastic. 3 really great answers there. Thank you to the panelists. There's one more question. It's coming from Dr. Iveth Gonzalez, who's asking, beyond health systems and services, would you have any comments on food security interventions? Some of you touched on food security in some of the answers earlier, but in terms of this particular question by Dr. Gonzalez, beyond health systems and services, would you have any comments on food security interventions? Lola, we're going to put you in the hot seat. Okay. Yeah. You're on mute. You're on mute. Sorry. Yeah.
Apologies. Oh yes, food security is very, very important. Again, although the men are the middlemen and they sell, the women are the purchasers. Now, it's in all the markets we work in Lagos, in Southwest Nigeria, and also in the Federal Capital Territory, you would find that food waste in the market could feed all of these women. There's a lot of food waste in the market. And so we're encouraging value addition to food waste in the market so that the women can store them rather than throw them away. So if you go to the markets in the evening, you would find that tomatoes, onions, vegetables, because they haven't sold them, they haven't sold all of them that day. Sometimes even fish, mackerel, they dump the waste. Food waste in the market is significant. And so one of the intervention points we have in the Tariro project is to enable women through financial inclusion to add value to food waste, sell them, and take some home and eat and feed their children. And so in many urban centers, we've gone beyond backyard farming because there's just not enough land. But because they're selling produce that they sell, the purchase in the market on a daily basis, we can add value to the food and also make sure that the food systems feed the women and the children. Thank you.
Thank you for that answer. Amita, would you have any input in terms of food security?
I think, from a food security perspective, it's again one of those areas that's really ripe for a kind of an integrated approach, right? Because if you think about school feeding programs, that's under the Department of Education. Nutrition programs typically have, a public distribution scheme, for instance, for food rations. And then of course, you have the role of the private sector, actually, when you think about food. So what are some of the ways in which you can bring all of these stakeholders together and have an integrated approach is, I think, really key and something we're diving into.
That's fantastic. Perhaps this study is going to become that blueprint for how things should be integrated. I have a feeling it will be, to be frank, because there's so many wins to be had on both sides of the nutrition side or the malaria side, the anemia side, as you've all explained. And I hope this does become the blueprint for further kind of integration. Roland, perhaps a view from you in terms of food security?
Yeah, sure. I mean, in an earlier answer, I tried to, highlight the importance of, good diets, of adequate intakes of nutrient for the functioning of the immune system. And certainly there are, direct links here between, therefore, food security, intakes, immunity, and then outcomes such as related to malaria. But specifically also what we're seeing in the context of COVID in many settings, due to the disruption of food supply chains, increases in food prices coupled with lower incomes or purchasing power, that many parts of the population are resorting to really consuming much more staple type of foods that are low in essential nutrients, sometimes also actually highly processed, unhealthy foods that have other problems related to them. So really what is entirely possible is that the intake of important nutrients is going down and that, immune systems are being weakened, that we will see increases in anemia and, with many adverse effects on, different outcomes, including possibly on malaria.
That's a fantastic answer. Thank you, Roland, for that. I'm very wary of the time. I think we've gone 5 minutes over in terms of our allocated time. What I would say is that all of these issues have been very neatly explored in quite a seminal report that I mentioned at the beginning of the session. The report put together by the RBM Partnership to End Malaria, by Unicef, by APLMA-APMEN in terms of the inputs for that report. Nutrition and Malaria, an integrated approach to effective case management. It's been launched today. It was underpinning, as well as World Nutrition Day, this particular panel. And I think that we've put the link up earlier in terms of the chat. Please do feel free to link yourselves into that report. And as I just mentioned, I really do feel this is going to become a major blueprint on how things are supposed to be done when you're bringing in different sectors. You really get the feel for that. And certainly from the positivity of the panelists and the answers that they've given, you're left with a lot of optimism in terms of how this is going to roll out. So I'd like to say a round of applause and thank you very, very much to all of you, to Amita, to Lola, to Roland. Some of the comments that have come through, so Dr. Harandi from Iran, thank you all. I appreciate your comments on this in reference to the gender inequality question. Dr. Halaskova from fully agree, GDP spending into health and nutrition and living conditions is a major and key element. So thank you for that. Lots of Dr. Abadole Jigo agreeing with all of the propositions being put through. Dr. Flavia Kagwa from Uganda. COVID has highlighted the importance of building resilient community health systems and fully institutionalizing them to support both malaria and nutrition programs. So you've got a lot of support out there in terms of the various inputs from the audience. We had we've got quite a few of those. I'm sure you've got those on your screens too. But it's been very, very well received. On that report, you'll see a list of the recommendations at the end in terms of recommendations that came out of that particular report for the policymakers, for the people that can make this integration real and make it happen. So I would strongly suggest you all read that report and familiarize yourselves with that. Again, thank you to the panelists, and I think we're going to have to kind of press that red button in a minute and back out this. Wishing you a very good rest of your evening. If it's Friday evening and you're going out, it's Friday morning here. We normally do it at 2 o'clock, but we've got a full day ahead of us. But wishing you a very good rest of your Friday and a fabulous weekend to everybody. Thank you so much to the speakers. Thank you. Yeah, thanks a lot. And thanks a lot to the audience. Take care. We'll see you next week. Take care. Okay, so I'm going to just switch it off from now. Thank you. Take care. Bye-bye.